we can pass to the second speaker of this session, Professor Carlo Alviggi. He is an associate professor in reproductive medicine at the fertility unit of the University of Naples Federico II. There are several interests, scientific interests that I know, and here are mentioned, you mentioned the role of the LH in folliculogenesis, the use of LH-containing drugs in a patient undergoing ovarian-controlled stimulation for IVF, and the pathogenesis of pelvic endometriosis, oncofertility, where we discussed several times, reproductive endocrinology, and the genetics of human reproduction. He is a starter and co-founder of the Poseidon Group, and at the moment he's vice president of CIFES, an Italian Society of Fertility and Sterility, and he's going away. So he collaborated with a lot of other groups and national and international, so it's a great pleasure to have you here. Thank you, Carlo.
Thank you, Francesca. I was not running away. Technical question. So thank you, Francesca, for your nice introduction, and I would like to thank Antonio and Livio for this nice opportunity because this meeting is intriguing, the topics are special, and what is important is the incredible possibility for discussing all together on very relevant topics. So I have a very difficult question. What drugs should we use? So I thank Antonio for this. Anytime he asks me to do something that is for some reasons dangerous, but I think that what we have to do today is understanding which drugs we have, and basically that drugs are different each other, and we have the possibility and incredible opportunity nowadays to personalize our treatment. And the question is like this: we are in Maranello, the history of cars. So what is better? What is the best kind of fuel we can use? A simple guide for drivers. We have classical petrol, diesel, we have gas and hybrid electric. So if I could ask you, every one of you, which is the best? This is something that we have to personalize, because some people prefer to be faster, some people prefer to have more economic, but you can say, I really love this kind of comparison because it's quite representative of what sometimes happens in our clinical practice. For instance, just to give an example, you can have something that apparently give high cost, superior maintenance, but on the other side, you can have lower fuel consumption, or in other cases, you can prefer comfort, you can prefer having the higher cost of purchase, but you prefer to have something that is more, I can see, efficient in terms of sustainability. So for the gonadotrophins is the same. We have a different product, and we have to adapt in our clinical practice. We have to know what we have, and we have to be able to match patients and protocols. And we have to adapt our resources to the kind of stimulation and the setting, because sometimes settings are different. You can have a situation where it's more convenient to have more blastocysts, you deploy the blastocysts, but you can have also public settings in which you have to focus on fresh transfers, and it could happen that you need to avoid some risks. So you have to balance. But at the moment, what I will try to do, and it is very difficult on my side to try to put this information in a consistent way, but I tried to understand according to the trends, to the news, I think the most modern way to work which is the best matching of patients and protocols. And I tried to develop the talk in three major questions, main questions. First of all, what is our expectation from ovarian stimulation? What do we want? It's the same I said for fuel, for cars, for car engines. What is our expectation? The second aspect is what can we expect from gonadotropin? Because we made a lot of mistakes, obviously, in the past, thinking that gonadotropins could do something different. So the question is how a gonadotropin can impact oocyte quality, quantity, and any single stage of IVF. Then I will try to summarize in a very rapidly which kind of the gonadotropins, which is the difference, and I will spend the last 2-3 minutes for, I can say, to try to develop an intriguing topic, which is one of the most relevant topics in the last years. What is the role of LH activities in our clinical practice? So let's move from the first point, and there is some overlapping with Barish, but I think that we need to focus on this aspect for better understanding the use of drugs in general and gonadotropin in particular. So any kind of a process have to be analyzed from two different sides. One thing is efficacy, which is the capability of a given treatment to give the success. So we have to define what is success, a specific endpoint, and what is the best way in terms of efficacy for having this result. The other side is the efficiency, meaning how I get that success. That in IVF means prevent complications, manage the risk of multiple pregnancy, ovarian hyperstimulation syndrome. In some settings, avoiding elevated progesterone levels during stimulation, and improving time to live birth rate is also a cost-effective approach in this, and not only cost-effective. So efficiency is the way we manage the capability of having our results. And so in the IVF, what we need in terms of efficacy is to increase the number of babies born per started cycles. In the last years, the relevance of a cumulative live birth rate as a best indicator of success became even more relevant. So this is something that Professor Atta presented. Now it's clear, the more is the number of eggs we have, the more is the chance to have a given number, an adequate number of blastocysts, and the more is the chance to have at least one euploid blastocyst. This is the paper by Nikos Politsos that has been presented before. This is related to fresh cycles, but if you analyze the difference with the frozen embryo transfers from pregnancies deliveries deriving from one single stimulation, you can see that even up to 25 oocyte, you still have progressive increase in chance to have a baby born. So the more is the number of eggs, the more is the chance to have at least one euploid blastocyst, the more is the chance to have success in terms of live birth. Why? Because this is another way to show what has been presented before. If you increase the number of eggs, the percentage of euploid blastocysts is constant, doesn't change. So increasing the number of eggs, we don't modify quality, we don't modify the percentage of euploidy. That means that having more eggs, I have more euploid blastocysts. So if in our setting, the aim is to have an all-in-one approach, one stimulation, one family, something like this, probably the most convenient is have the highest maximizing the number of oocytes to increase the absolute number of euploid blastocysts. This is related to ovarian stimulation. But we don't have to forget all these points, efficiency and whatever. The problem is what can we expect from a gonotrophin? If I have an antral follicle count at the beginning of my stimulation of 5 antral follicles, can I expect to have 10 oocytes? Gonotrophins cannot create. I cannot understand why sometimes a starting dose of 400, 500, 600 international unit of a gonotrophin is given. You cannot create. You are not in time to have new follicles. If you start from a given follicular wave, you can have the number of oocytes consistent with that antral follicle count in the cycle you are using for stimulation. And so that's the reason why, if we ask a gonotrophin to maximize the number of oocytes in a given cycle, what I have to ask is to optimize, to exploit the ovarian sensitivity. That's the reason why I think that in our clinical practice, we need indicators that are focused on the moment of ovarian stimulation with a given question. Was the number of follicles growing, or was the number of oocytes retrieved consistent with my baseline, with the starting point? Because if I have a situation like this, meaning that I have 3 oocytes, and at the end of stimulation, 4 big follicles, major follicles, but my starting point was 15 antral follicles. It means that I didn't exploit the ovary in a right way, because this patient had low sensitivity to gonotrophins during stimulation. So probably I have to change my stimulation. Probably I need a different gonotrophin. Probably I need a higher dose. But at the end, I have 3 eggs, and the prognosis is related to this number of eggs, but the potential of this patient was higher. So I had a low follicle output rate and low follicle to oocyte index. Here we have another case, which is quite the same in terms of prognosis, the same age patient, again with 3 oocytes, but this patient had 4 antral follicles at the beginning of stimulation. So in this case, I can say people call this patient a poor responder. In my opinion, this patient is an optimal responder. The ovarian sensitivity was perfect because I had from gonotrophin the maximum that I could have. So I don't have to change, no, I don't have to consider to change my, my stimulation in the next cycle. So having a look to FORT, that has been proposed by Renato Fachin many years ago, to the oocyte to the follicle to oocyte ratio, is very important not only for clinical trials, for deciding which gonotrophin we should prefer in any given patients, but it's also important for testing our clinical practice in terms of total quality management. Because if you have a look to the Maribor criteria, very nice for defining key indicators of performance in IVF, they are basically lab KPIs. We need KPIs in our clinical practice. Any single month, every 3 months, we have to understand if FORT, if FOI in our clinical practice are consistent with the expectation. Because if a vast majority of patients has a FOI below 50%, it means that something is not going properly, and you have to understand at which level. In comparison with the FORT can be the maximum possibility, an incredible opportunity for understanding if the problem is matching patients and protocols or triggering, timing of triggering, or something in the setting of egg collection, which is not working properly. So this is what we did in Italian Society of Fertility and Sterility. We proposed the FOI as indicators for testing our capability in the clinical practice for exploiting at the maximum level the potential of the ovary. So the first point of the talk is what is important is maximizing the oocyte yield exploiting the potential of any single patient. And to do this, we need to match properly patients and protocols. So I go rapidly to the second point, which kind of gonadotropins we can use. So gonadotropins are different each other. This is what happened in the last years. So at the end of the history, we start with the pituitary urinary recombinant. Now we have different kinds of recombinant, different kinds of even long-acting. So we have the possibility of choosing so many different gonadotropins in our clinical practice. But I would like to give you a sort of, in just 1 minute, I want to tell you that the structure of, for instance, FSH, which is the driver of our ovarian stimulation, is quite similar. This is naive molecule, and Livio obviously will show you properly. I can just mention this, and how can you can say that we have a specific point of glycosylation, and the carbohydrate chains are very crucial in defining the activity and defining the clearance, defining pharmacokinetics and dynamics of any single gonadotropins. Because if the glycosylation is higher, if we have more sialic acid sites, the clearance is longer and the gonadotropin is more acidic. If we have a lower quantity of sialic acid, obviously the clearance is faster, and we can say the characteristic of the gonadotropin at receptor site are totally different. To give you an idea, this is a list of all the commercially available preparation of FSH, urinary and recombinant. You can see, for instance, which is quite clear, that folitropin alpha, which is recombinant, is, for instance, more basic than urinary. And even in the same category or similar categories, which is recombinant FSH, we can have differences in terms of acidic or basic profiles in terms of isoform. But coming back to the idea of a different fuel, what is the main concept we have to keep in mind? That if we have a dominance of acidic isoform, which is typical of HMG or urinary gonadotropins in general, we have to consider that we have slow follicular maturation but longer half-life and less power binding at the receptor site, less acidic isoform, we can say basic isoform like folitropin alpha and recombinant FSH in general, have rapid and powerful stimulation of follicles. So let's come back, and if you have a look, the stronger binding but more renal clearance. So the profile is totally different. Let's come back to what happens in nature. In nature, even during the same follicular phase, we have physiological changes in the profile of isoform of gonadotropins. So, for instance, at the beginning of follicular maturation during menstruation, we can say when follicle classified follicles between 29 millimeters, and so the ovaries and the last steps of selection of codominant and dominant follicle, there is a dominance of acidic isoform because this has to be progressive and the selection has to work with the maturation of dominant follicle. But in the last steps of maturation, when the cytoplasmic maturation has to be realized, we have a dominance of a basic isoform because everything happens, and I will show you in a few minutes, inside the cytoplasm is crucial for the survival of the oocyte and the embryo viability. So in nature, there is a different profile of gonadotropins, even in the same patient, in the same menstrual cycle. But in IVF, we need the opposite. We don't need to select dominant follicle. We need to select more follicles in a very rapid way. We need to overcome dynamics of follicular selection. So we cannot think to use gonadotropins biomimicry natures at any single level, because we have a different aim. We have the aim of maintaining quality, maintaining cytoplasmic maturation, but at the same time, we need multiple follicle growth. So if we go into clinical practice, all the historical trials, even comparing urinary with the recombinant FSH, provide the same information. With the recombinant FSH, you increase the number of eggs. So because the link to the clearance is lower, but the stimulus is more dynamic, the gonadotrophin is more potent. So if you need to make more follicles growing, you need a given gonadotrophin. It has been also confirmed in an incredible retrospective analysis that has been performed many years ago by an English group, by Jeff True, and they analyzed the European registers, one of the first example of real-world data. More than 30,000 cycles were analyzed, and it was quite clear by numbers that at any given age, if you use recombinant FSH, you have more eggs, and what is very important, with the lower dosage in terms of international unit. So one concept to keep in mind is that if you want to maximize the number of eggs, you have to push the system since the beginning, and probably the best way to do it is using recombinant FSH. And this is to show that this is true at any given age. I want to spend you just 1 minute on something that happened some years ago. This is an historical trial. This is the MERIT study, where the recombinant FSH was compared with highly purified HMG in fresh cycles. The endpoint here was the live birth rate in fresh cycles. Let's have a look. In this case, agonist-long protocol was adopted. It was randomized controlled trial. And what is very important, the starting dose in very good prognosis patients, these are patients with very good ovarian reserve, was 225 international unit. What happened in the trial? What happened in the trial was that patient treated with recombinant FSH has a significantly higher number of oocytes retrieved, confirming what I said, more eggs with recombinant FSH. But they also had higher incidence of progesterone rise. So coming back to the fuel, what I said at the beginning, if you push the system and you have more eggs, you also increase the stimulus in granulosa cells. And I don't have time to explain this, but the take-home message is that progesterone rise is an FSH-dependent mechanism, phenomenon. It's not LH related. What does it mean? It means that if I have a more potent gonadotrophin, recombinant FSH, I push the system, I move a lot of follicles, I optimize my FORT and my FOI, but I run the risk of moving more progesterone. So what to do? You have two chances. The first is understanding that this gonadotrophin is more potent, so probably you don't need to start with so high doses. If you start with 225 with the HMG, probably you can start with 150 to avoid this movement in progesterone. Or the other possibility is not taking care of progesterone rise, because you have robust lab, freeze-all program, and 90% cycle segmentation. But what I said at the beginning was the best car engine is the one which is more consistent with your setting. If you have no problem, if you want more blastocysts, if you want to do PGTA, if you want to optimize oocyte health, probably progesterone rise is not a problem. So it's up to you, but what is important is understanding how a given gonadotrophin works. And with the recombinant FSH, we have a more potent gonadotrophin, more eggs, but if we push the system too much, we run the risk of moving more progesterone. This is just something to manage. The same group performed the trial again, HMG versus highly purified versus recombinant FSH some years later, and they started with 150 international unit in antagonist regimen this time, and the difference in progesterone rise disappeared. This proves, in my opinion, that it was just a matter of starting dose of recombinant FSH. So I would like to show you something that, in my opinion, has not to be under-evaluated. Do you remember the first question? What can we expect by gonadotrophins? So can gonadotrophins create new follicles? No. Can a gonadotrophin optimize FORT/FOI? Yes. Can a gonadotrophin change the oocyte quality, the embryo quality? We don't know. The only thing that we can measure is euploidy at the moment. And so we tried in the network with Genera and Federico II University, we tried to pull all the data together. And what we understood, it is not so huge sample size, is that all these combinations has no impact on the rate of aneuploidies. So we can increase the absolute number of oocytes, we can have more chance to have euploid by quantity, but at the moment we cannot say that the gonadotrophin can change the rate of euploidy. This is very important because a question that has to be always taken in our mind. I skip some slide because I want to go straight to the point, to the end. What about LH? LH, Livio will talk later, I think, about the relevance at the receptor site, what is the role of LH, but what is clear is that above 35 years of age, the LH activity is decreased in terms of biological LH produced by pituitary gland, isoforms change, the endogenous LH is less efficient, and all the endocrine paracrine activities, the paracrine activities at the level of the ovary are conditioned by this change in it. The production of androgens is lower. So when we test recombinant LH in our clinical practice, for instance, what we have to ask is, what is our expectation? Because if our expectation is having more oocytes, probably we will be disappointed. That's the reason why when the ESPAR trials was performed, the huge trials comparing recombinant FSH plus recombinant LH versus only FSH, recombinant FSH, it was found no difference in terms of the number of oocytes retrieved. I would like to remind you that they were poor responders according to Bologna. Vast majority of patients was close to 40 years of age, and the ovarian reserve was very low. So it's not surprising because no gonadotrophin can create new follicles. But have a look at the post-hoc analysis. Obviously, it's a post-hoc analysis, but in live birth rate was a little bit higher. Why? Because the miscarriage rate was lower. What does it mean? It means that probably LH is not able to change the rate of aneuploidies, is not able to create new follicles, but is very important at different level. Genetic, no, aneuploidies are the same, but embryo viability and embryo competence, the capability of the embryo to give implantation to maintain early stages of pregnancy is strictly related to a relevant aspect that is cytoplasmic maturation. And cytoplasmic maturation of the oocyte is something that occurs in the last weeks and in the last days before ovulation. And what is important for cytoplasmic maturation is the quantity, is the junctions related that are crucial between oocyte and granulosa cells. And so if the cytoplasmic, there is an incredible increase in the volume of the oocyte, even 60 fold increase in the volume of oocyte in the last step of oocyte maturation. And the only thing that regulates the oocyte cytoplasmic maturation is the quantity of cells that are in dialogue with this oocyte. And the quantity of cells is regulated, Livio, tell me if I say something wrong, is regulated by the anti-apoptotic local activities. And only LH, in clinical practice, recombinant LH has this anti-apoptotic, because ACG is good in supporting steroidogenesis, but is not anti-apoptotic. So if we provide ACG in our stimulation, we are pushing the system in steroidogenesis, but we are not protecting granulosa cells against apoptosis. So the more is the number and the quality of granulosa cells, the better, the more is the quality of cytoplasmic maturation. That's the reason why it's not surprising that if we change the angle and we study recombinant LH, not in poor responders according to Bologna, but in patients above 35 years of age, we don't find any change in the number of eggs. We don't find any change in the percentage of M2 oocyte, but we found a statistically significant increase in ongoing pregnancy rate. And this effect disappears above 40 years of age. Why? Not because LH is not working above 40, but because LH doesn't change aneuploidies. And so above 40, the relevance of aneuploidy rates is too much dominant. It cannot be counteracted, at least in small sample size, by any kind of gonadotrophin. So I'm sorry if I took some more minutes, but I don't have a conclusion slide, which was my decision, because the take-home message, in my opinion, is this. What can we expect from different gonadotrophins? No effect on ovarian reserve. We will discover this afternoon if pre-treatment with LH or androgens can change. But in a given cycle, I cannot create new class 5 follicles. Age-related aneuploidies. At the moment, we don't have this information. At the moment, the answer is no. But we can optimize ovarian sensitivity, so the relevance of fourth and four in our clinical practice. And probably we have to understand that there is something different in terms of oocyte competence and oocyte viability, which is different from aneuploidies. So I thank you for your attention for this presentation.